my pleasure to invite Dr. Valentina Bruno to the podium. Dr. Bruno is a pediatric nephrologist and assistant professor of pediatrics, Faculty of Medicine at the University of Toronto. She is the medical director of the dialysis and apheresis program at the Hospital for Sick Children. She completed her medical degree and pediatric training at the University Federico II in Naples, Italy, and her nephrology fellowship at the Hospital for Sick Children in Toronto. After that, she pursued additional training through the Complement-Mediated Diseases and Apheresis Fellowship program at the University of Toronto, which is actually marking the beginning of this fellowship program. So she is the inaugural fellow of that program, during which she completed a Master of Science at a project at the Institute of Medical Science. She was studying the role of complement in the pathogenesis of primary membranous nephropathy. Dr. Bruno's clinical and research interests are in dialysis and apheresis, glomerular diseases, and complement-mediated diseases. Valentina, please enjoy the stage and enlighten us about treatment.
Thank you. Thank you, Christophe, for the introduction. Good morning to everyone. Thank you to the conference organizer for inviting me today. It's really a pleasure to be here to discuss about treatments in atypical aHUS, where we came from and where we are going. So as Christophe was mentioning at the very beginning, unfortunately or fortunately, you will see this picture over and over during the day, but I think it's the only way to be able to connect clearly the dots between pathogenesis and therapeutic options in this disease. As we know, the complement system plays a major role in the pathogenesis of atypical aHUS. It can be activated through those three main pathways, but whatever is the main pathway initially involved, the activation of those pathways will lead to the proteolysis and activation of this C3 protein. And this is really the initial trigger of a truly like a domino effect, right? So after the C3 is activated, this will lead to all the downstream effects, so activation and proteolysis of all the other complement proteins, in particular the C5, which then will lead to the formation of this C5b9 channel, which is a protein channel which is inserted, formed, and it deposits on the surface of the endothelial cells, forming pores, and starting like in this way the endothelial injury. Of course, since this is, if we are not able to control this cascade, this is truly like a domino effect. We need to make sure that the system is regulated, and fortunately we have several proteins who are able to control the system. In particular, they are able to control the hyperactivation of this regulation of the alternative pathway. All those regulators, the main regulators, are membrane-bound. Some are more like circulating factors, but they all, in different ways, try to control this cascade. Now, when we speak about atypical aHUS treatment, what are we targeting? Of course, considering the main role of the complement system in the pathogenesis of the disease, we are targeting this cascade. But as I will show later, this cascade can be targeted at different levels. It depends what we are trying to block, which type of medication we are using, and I will explain in a moment. Now we are speaking, and we already mentioned during the previous presentation, about drugs, but as we know, drugs are available since 2011. Before, it was absolutely not like that. It was mainly supported treatment, and I will say that the main component of the treatment in this type of patients was plasma therapy. So when we speak about plasma therapy, we mean two main things. Plasma infusion, so we are giving plasma, fresh plasma to the patient to replace the deficient complement proteins, or we can do therapeutic plasma exchange. If we do therapeutic plasma exchange, it means that, as we can see here in this picture, the patient will be connected to an extracorporeal circuit, to a machine, and basically there will be like an exchange between the plasma of the patient, so a percentage of the plasma of the patient will be removed to then provide fresh plasma, and in this way we are able to achieve two main aims. One is the replacement of the deficient proteins, and then on the other side, we are also able to actively remove abnormally functioning proteins or autoantibodies, for example, like in the anti-factor H disease that Priyanka will discuss later. So based on this concept, of course, if we look into the literature and we try to identify the first guidelines for the treatment of this condition, those recommendations from 2009, as you can see, were not mentioning any drug at all. After making the diagnosis of atypical aHUS, the recommendation was, of course, to start immediately within the 24 hours or anyways, like as soon as possible, plasma exchange, initially daily, and then gradually tapering the treatment, and then reassess the outcome after like about a month. This is also a slide that was initially shared, but I think it's important to highlight again the message. So as you can imagine, the plasma exchange was not really treating this condition, because it was not really actively targeting the inhibition of the complement cascade. So it was just trying to control things on the surface in some way. So despite maybe an initial response of the patient to this treatment, the rate of remission, depending of course on the type of the genetic defect that we were highlighted, so the rate of response, so rate of remission was like very variable, but I would say about 50%. We go from 30 to 70%, like depending on the mutation. And then the long-term outcome, unfortunately, the rate of death and end-stage kidney disease, so like kidney failure, was pretty high, as we discussed before. 2011, like in the rest of the world, but in particular 2013, I would say in Canada, of course, is a milestone in the history of atypical aHUS, because we know that here the drug, basically, the first complement inhibitor, was approved for the treatment of this ultra-rare condition. And I would say that, of course, the approval didn't come through very easily. Before the time, there were a few case reports were demonstrating that the complement inhibitor, in particular eculizumab, was having a positive impact, was really like helping patients. For example, here you see the graph of a patient who was initially, patients of course with a diagnosis of atypical aHUS, who was initially treated with plasma exchange or plasmapheresis, like we are saying the same thing, for multiple sessions without clear improvement. The platelets count was low, the creatinine, which is a marker of kidney function, was high, hemolysis markers continued to be there, so there was no clear response. And then as soon as the patient was started on eculizumab, you can see like this acute, like immediate response, the platelet counts that increases, the kidney function that improves, and also the hemolysis markers were, of course, improving as well. And same thing, this is another case report, was in particular highlighting the response to eculizumab for a case of congenital atypical aHUS. But I would say that really the milestone, of course, in the literature of aHUS is this paper. Thanks to, and I'm saying that this is really the milestone, because thanks to this study, really like we were able to finally get the approval for the drug, because all the data basically from those trials were of course reviewed, assessed, and it was really the final yes to have the drug available on the market. This particular study was looking at 2 prospective phase 2 trials. So patients with a diagnosis of atypical aHUS with an age of 12 years or older than that received eculizumab for initially the 26 weeks, and then they were initially looking at the 26 weeks, and then later there was a long-term extension phase. And the 2 trials had slightly different type of patients. Trial 1 in particular was looking more at the acute patients who were having a progressive TMA, a progressive atypical aHUS, while trial 2 was looking more at patients who were diagnosed not immediately, so they were more long-term diagnoses with maybe a stable platelet counts during the observation period. And what they found, in both cohort, trial 1 and trial 2, is that you could clearly see here, for example, we have the response to the eculizumab, showing basically the change in the platelets count, the eGFR, which gives you an idea, a percentage of the kidney function, and basically patients were able to respond to the treatment. So you can see this increase in the platelet count, you can see an improvement in the kidney function, and this is not just an immediate response, is actually an acute response, which also stays there long term, because you can see for the full 26 weeks period there was an improvement, and this was also evaluated long term in the extension treatment period. Other study which was really telling us that this medication was working in this patient is this other study, which was basically looking at efficacy and safety of the drug in atypical aHUS from 2-year extension of these phase 2 studies that were showed before, and same thing. Those graphs are basically just telling us that the response was clearly there, and it was prolonged over time, was not just an acute improvement. Of course, when we speak about complement inhibitors, in particular the terminal pathway inhibitors, we are always concerned about possible infection, in particular the risk of meningococcal infection, but there was actually no cases of meningococcal infection reported. Of course, patients received the immunization or the antibiotic prophylaxis against the Neisseria meningitis as per guidelines. And this is to say that after, of course, all this literature basically led to the development of new guidelines. So we switched from the 2009 initial recommendation, where plasma exchange was really the main treatment. We moved to the 2016, where actually for the same condition, atypical aHUS, this time first-line treatment, as you can see here, becomes eculizumab rather than plasma exchange, and a plasma exchange is an option there in case the drug is not available. So that was really a huge change. And just to highlight and reinforce the message, this is also in keeping with what the ASPA is recommending, which is the American Society of Apheresis. So basically, if you look at the list of thrombotic microangiopathies, the only category for which plasma exchange is considered category 1, which means that is accepted as a first-line treatment, is only for factor H autoantibody atypical aHUS. While, for example, if you have atypical aHUS in the context of complement gene mutation, it becomes category 3. Category 3 means that based on the center, based on the choice, based on the availability of the drug, you can consider or not, but it's absolutely not the first line. The first line is actually the complement inhibition. So as we were mentioning at the very beginning, we can target the complement cascade at different level. In particular, when we speak, we mentioned right now eculizumab, which is, of course, the first drug that was developed for this disease. And we know that eculizumab is blocking the C5. It's a monoclonal antibody with blocking the C5, basically inhibiting the terminal pathway of the cascade. What does it mean? That whatever is the pathway that is activated, the classical, the lectin, or the alternative pathway, at the very end, the C5b9 or like MEK is inhibited because there is this blockage of this C5 protein. But there are now new drugs which are like coming and they are being evaluated. Some of them have been evaluated already and available for, in particular, for adult patients. So if we think about the C5 inhibition, we have, for example, other type of drugs like ravulizumab that I will mention like in a moment. But all of these are still targeting the C5. It's just a different way. Like some of those medications, for example, instead of being given IV, it could be given subcutaneous, or maybe the interval between the infusions IV, like it's different, and I will tell you in a moment. But they are all inhibiting the C5. While more recently, there are studies that are also looking in particular at factor B, in particular the factor B inhibition. We know that factor B is one of the main components with contributing to the activation of the alternative pathway. So there is this drug iptacopan with specifically blocking factor B, so blocking the alternative pathway. And we will see, like I'll show you a little bit like the design of the study. This is a list of the new complement blockers for this condition. And I highlighted the ones who are mainly developed for atypical aHUS, because you will see here there are other medications in the list who are more developed or like considered for secondary forms of TMA rather than atypical aHUS. So now let's go to part 2 of this talk. I explain where we started and how things were managed a while ago and how things changed after the introduction of eculizumab. But there are new options that maybe can make life easier, or maybe not. Like it depends. Let's see. So we have this new medication, ravulizumab, which is a long-acting C5 inhibitor. The big question is, this medication is now there, is approved, but is approved for adult patients with atypical aHUS. Is it time, and this is since November 2022, is it time to switch? Should we just start all the patients on this new drug, or maybe should we switch all the patients on eculizumab to ravulizumab? I explain here like already what is the target is basically exactly the same as eculizumab, but the big difference is that is the dosing basically. So eculizumab has an half-life of about 11 days, and I'm sure that maybe you are familiar with this like dosing schedule, but based on the different weight of patients, you have this induction phase, and then you have the maintenance phase where for the majority of patients is infusion, like different dose, every 2 weeks. While the big difference with ravulizumab is that the half-life is much longer, is almost like 60 days, about 56.6 days. So because of that, it allows us to basically reach the same aim, which is blocking the terminal pathway of the cascade, but increasing the intervals. So the medication in this case as well, based on the weight of the patient, needs to be given IV, so same as eculizumab, but will be given every 4 or 8 weeks. Now there are studies who are actually suggesting, highlighting that this is probably like the new course. It's something that we should really consider. We have phase 3 single-arm multi-center trial assessing the efficacy and safety of ravulizumab, who was administered through IV infusion in 10 pediatric patients with age less than 18 years with a diagnosis of atypical aHUS. And they actually looked at 2 different cohorts. So they look at patients naive to complement inhibitors, so diagnosis and never started on any other drug, or patients cohort 2 previously treated with eculizumab. And basically, this is the design. In this particular case, you see like the design of patients who were previously on the medication, on the different medication, eculizumab. So in that case, the last dose of eculizumab should be given 14 days before starting the new drug. And then you have this initial, after starting the new drug, ravulizumab, they look at initially at this 26 weeks, so like almost 6 months, and then they also had the extension period, not for all the patients. It really depends on if the patients wanted to like be part of the extension period, if the drug was available for the extension period, and in any case, it was up to 4.5 years. And basically, what you can see here clearly compared to the baseline, so those are patients who were initially treated with eculizumab. So compared to the baseline, you see that both the trend of the platelets count as well as the hemoglobin stays the same. So over time, you don't see that the platelets count is falling down, or same for the hemoglobin. Like you don't see any any signs of recurrence, basically. Other important thing, of course, is side effects. We are always worried about these, and in particular, same story here as well, meningococcal infection. But actually, they couldn't really report any big side effect, and in particular, they couldn't see any meningococcal infection. We have also recently published another study who is incorporating both adult patients and pediatric patients, and they're looking at 2-year efficacy and safety outcomes in both cohorts. And in particular, they were looking at adult patients naive to C5 inhibitor, and then they also incorporated this pediatric cohort that we just discussed. So pediatric patients naive to eculizumab or previously treated with that. And as you can see, for patient, this is for the naive cohort, both adult patients and pediatric patients had a very good response to the ravulizumab. This is the overall trend of the full TMA response, and then here we have specifically the trend of the platelet counts, the hemolysis markers, the platelets counts, and you can see that both at 26 weeks, so the initial observation period, up to 2 years, there was a clear response, and it was sustained over time. Just to look a little bit more into the literature and what is there supporting ravulizumab, there is also the analysis of the global aHUS registry of patients who were switched from ravulizumab to eculizumab. Same thing, this study was including both adult and pediatric patients. And as you can see here, just really looking at the bars, here you have the total number of patients, and in particular at the very top, the blue line is the pediatric patients. You really don't see any difference in fluctuation of the kidney function at the top and the platelets count at the bottom. So data are really supporting us basically to go towards this new pathway. As I mentioned at the very beginning, there are also alternative strategies to block the complement cascade. And more recently, there is this study who is looking at the factor B inhibition in atypical aHUS. And this is a pivotal phase 3 study designed to evaluate the effects of the potential benefits of this medication. I think in this case, the huge difference is that instead of being an IV medication, is an oral medication. The study is mainly designed for adult patients, naive in this case, to complement inhibitor therapy. So they will receive for a certain amount of time the iptacopan 200 milligram BID, and then of course they will look at the all the outcome along the treatment. Of course, this is just we don't have data for that yet. So this is hopefully at some point, maybe next time, we'll be ready to review some of the results. And this is, yes, so this is what I wanted to highlight. Factor B inhibition in this case is targeting in particular the alternative pathway. So it's also in some way blocking this amplification loop, blocking the alternative pathway. And in this way, I think another reason why this medication could be maybe more should be considered as well is because it's not just is not blocking completely the terminal pathway, is blocking part of the terminal pathway that you have through the activation of the alternative pathway. So basically, the other two pathways are still there. They can be activated. So it means it's kind of positive and negative effects, because from one side you can say, okay, maybe this is a less strong way to block the cascade because you're not fully blocking the terminal pathway. On the other side, of course, you can, if you think about possible side effects, since you're not blocking completely all the MAC formation, you could maybe have less side effects. But it's also true, as I showed before, that we didn't really see any big side effects with the current C5 inhibition therapies. Big question that I heard already. Oh, first of all, is there any questions so far? You can always ask anytime. Yes.
So I did have a quick question. It's more about the trials that were done.
Yes.
Oh, thank you. So when I originally got sick, it was in 2012. And I got my treatment then. I was at Sick Kids, but I was 11 years old and it was in 2012. Would it have still been part of phase 2?
2012, so we are speaking about, because at that time we didn't have any of these, right? So we didn't have ravulizumab. Factor B inhibitor is something that now is being considered only for adult population.
Yeah.
So it would have been really the option would have been the eculizumab.
Yeah, I was on the eculizumab, but it wasn't approved then. So would it have been the phase 2 trial I was on, or?
I'm not sure I'm understanding the question.
I can answer from history.
Yeah.
So the trials were completed at the time when you were. If I may share that. The trial was completed at the time, or enrollment into the trial was completed, but you were in this window during which we had the drug established, as we heard, with all the data, but no reimbursement kind of process.
Okay, you were mentioning the funding. Okay, I didn't get that. I will discuss about that in a moment as well, the funding part. Sorry, I didn't get the question.
Could you explain a little bit more about the pros and cons of blocking the complement pathway at different points?
At the different points,
Just a little bit more expansion on that.
Here. So basically what I was trying to say is that with the type of drugs that we have at the moment, eculizumab and more recently ravulizumab, we are blocking the C5. In this way, we don't really think about which is the predominant pathway that is activated between classical, lectin, or alternative. Whichever is the pathway, all those pathways will lead at the very end to the activation of the terminal cascade leading to the C5b9 formation. This is really the main step. So we are blocking this, and we don't even need to think about, is it just the alternative pathway that is involved? Maybe there is also some activation of the classical pathway. Like we don't need to think about that. It's really just we are just blocking the final step. So we are completely inhibiting the main step to leading to the cellular injury. If you consider the factor B inhibitor, it means that you are targeting in particular the alternative pathway, which we know, of course, it's the main pathway involved. But you can still have, if there is any sort of mild activation of the cascade through the other pathways, there is still a mild activation that could lead to some degree of C5b9 formation. So basically, the team who was developing this drug was thinking that maybe in this way is a sort of like less aggressive way to inhibit the cascade in order to mitigate possible side effects like severe infection. But then what I was also saying on the other side is that truly with the C5 inhibition, we didn't really see any severe infection like the severe meningococcal sepsis, also because we have our patients vaccinated on the prophylaxis, so we really didn't document that. So if, like, my personal opinion is that I'm not, of course, we really have just the study design. We don't have any data from this study, so we don't know what will come from that. And it is also dedicated at the moment only to the adult population. But to be honest, and the other thing is that compared to the other medication, is an oral medication and not an IV infusion. But again, we need to really look at the data to understand if it's really something that we should consider in our aHUS population.
Blocking the C5 or even the factor B.
Yeah.
In a healthy individual, what would normally happen that is not happening in a patient? Would it just be the susceptibility to things like infections? Is that it?
Yeah.
Or is there other components that the immune system would normally do that is now limited as a result of the blockage?
The main component will be really infection, because as I don't know if we clearly mentioned at the very beginning, the complement system is part of the innate immune system. So it's really like the first barrier that our system has to fight infection. So this is really the main the main component and the main worry, that if we block completely this cascade for a very long time, from one side, of course, we are switching off the mechanism that is leading to the atypical aHUS, but then from the other side, there is increased risk of infection. But with the type of approach that we are using, so vaccination and prophylaxis, we don't see, like in our personal population, we don't really see any of those severe reaction. And also looking at the data, really, if you look at the trials, they don't really report any like huge complications like that.
Okay, thank you.
Any other
question?
Yeah.
I'm currently on exclusumab, and I have the option to switch to the other drug. And I'm from Calgary, Alberta, so the medical, how it all works is provincially, right, with the medication coverage. So I have to find a different avenue to find coverage for the other drug to get off of the Solaris, to have the fewer treatments.
Yeah, that's it's absolutely a big point, and I will discuss about that in a moment. Of course, I'm going to share what has been developed in the hospital where I work, so is the Hospital for Sick Children. I'm not sure exactly. I know that, of course, different provinces have different rules, unfortunately. So I don't know exactly in that area how things work. But yes, I recognize that there is it's a sort of like inequity, basically, right? That they're based on the place where you live, you can have more or less access to new drugs. Thank you. Yes, yeah.
It's the three-parter, sorry. I'll do the easy one.
Yeah.
Are you able to, sorry, thank you. Are you able to tell us which company is making which drug? So eculizumab and ravulizumab, sorry?
Yes, so eculizumab and ravulizumab is the Alexion company.
Yes.
I'm pretty sure, I don't want to lie, so I'm going back to the old slide. Factor B, I think, is Novartis, yeah.
Okay, thank you. And back to the chart that you had last with the factor H,
Yes.
the pill hitting the factor H, and the other two hitting the C5.
Yes.
Back 10 years ago, the C5 is where they wanted it to hit because everything was covered. And looking at the complement slide that was up earlier, is it too simplistic to say that if somebody is diagnosed with only factor H, that pill would be good for them, and somebody who's diagnosed with a C mutation, the other ones would be better? Like, is there that line of thought at all?
Yeah, I mean, it's a good question, but I don't think we are at the point where we can really, clearly say, okay, if we document, also because it's also like complicated, since like all the pathways at the end lead to the same point, which is the activation of the terminal pathway. We have, of course, some markers which are suggesting the activation of one pathway more than the other, but it's not completely black and white. So at this stage, I wouldn't be able to say, okay, if we document more activation of this, then let's go with this drug rather than the other. I think it's super premature, and I'm not even sure if also later with the data from the new studies, we will be able to say that.
And this is not in your realm, but I'm going to put it out there, is cost a consideration?
So, yeah. So I know, again, for the factor B inhibition, it's really just the study design. So we don't have data there, so I don't have information about that. I know that if you compare eculizumab versus ravulizumab, at the end, actually, the costs with ravulizumab are less compared to eculizumab. Yeah, please go ahead.
So, for any kind of infections, this C5 complement then a breakthrough or just for aHUS case? Like any kind of infection?
Oh, yeah. So any kind of, you're asking if any kind of infection can trigger the cascade, right? Yes. So this is any type of infection, but we know that in particular, this cascade becomes even more important in atypical aHUS because there are complement genes abnormalities or autoantibodies who are activating, dysregulating the cascade, and that's why it becomes a big problem in this condition. But any type of infection can trigger and actually this is the normal response.
Like we have some kind of cold, right? The degree of severity in the cold sometimes happens, right? Sometimes we have runny nose, sometimes we have teary eyes, sometimes block or something. So there is any category or something which can, like...
No, I think we cannot say. I think if I understand your question, you are trying to understand if there is, like a sort of degree. No, like this is really part of the, it's not like a specific type of, how can I say, like of immune system. It's really like part of the innate a specific, so non-specific response to to any type of like infection and external trigger.
And this C5 complement would cascade.
Sorry, I just want to add that, of course, you don't really feel any of these activation. So you don't feel that your complement is, like the fire is on in normal condition, because as I explained, while any type of infection can trigger this cascade, we have all the group of complement regulators which are able to control this cascade to avoid this domino effect that I was showing at the very beginning.
So in this case, let's say aHUS is having, let's say we know like this is getting trigger or something which is making it to a aHUS factor, right? So then let's say somebody is having something different disease, how it overlaps with aHUS, and then what kind of prevention we can say, like say for diabetic patient or something, if they have, aHUS or something.
So again, I hope that I understood what you're asking. But if you're asking about possible
Overlaps
between, I don't know, infections and atypical aHUS, yes, of course, we can have overlap, and actually is also documented that in patients with atypical aHUS, an infection, even if we're not speaking about stack aHUS, but an infection can initially be the trigger. And then since in that specific patient you have dysregulation of the cascade because of complement gene mutation or because of those autoantibodies who are circulating, then in that case, your system is not able to control the hyperactivation of the cascade, and then this will lead to all the downstream effects, cellular injury, and then very quickly to the thrombotic microangiopathy picture. So yeah, absolutely, you have like a little bit of overlap.
You have more to go, right?
Yes, but I'm also happy to answer more questions if there is time. I'm not checking the time, so. Okay, so I will continue. Yes, so I heard at the very beginning, this was a big question. Once we start the treatment with atypical aHUS with complement inhibitors, for how long do we need to treat our patients? So because of the risk, of course, of relapse after discontinuation, initially the complement blockade was proposed as a lifelong therapy. So once you start and you document that the patient has atypical aHUS with like complement abnormalities, you continue like long term. But of course, this approach needs to be balanced between the risk of relapse, of course, we know after discontinuation, versus the risk of infection that you can have long term, and also the high costs. Of course, in healthcare, costs shouldn't matter really. But unfortunately, this is also like one of the main problem, right? So we need to think about what we are doing and if it's really needed this like long-term therapy, or maybe we can aim for a shorter treatment. So before moving to the next study, I want to say clearly that at the moment, we don't have specific like recommendation telling us, okay, after 6 months or after 1 year or after 10 years, just stop the medication because it's not required anymore. We don't have that recommendation for the moment, but I know that there are new international guidelines who will be they've been like developed, and I think they will be like published and shared with everybody soon. Christophe is leading that, so hopefully we will hear soon like from those new guidelines, and we will have probably better ideas. What I can share now is what like the most recent evidence is supporting, and what like the some centers like tend to do. So, for example, there is this particular Cure-iHUS study. This is the Netherlands group, who is actually highlighting that an early eculizumab discontinuation in patients with atypical aHUS, we're speaking about native kidneys, it's safe and is also cost-effective. So what they did here, they treated both pediatric and adult patients with atypical aHUS with eculizumab for a 3-month period. And then they documented, of course, a risk of relapse, because we know that there is a risk of relapse. And after the discontinuation, they documented around 22% of relapse rate. Of course, in that specific case, they restarted immediately the medication, and they didn't really have any like long-term chronic sequelae, like, I don't know, hypertension, proteinuria, or impaired kidney function. All of this was not observed in patients who had relapsed after discontinuation, because of course they also were immediately retreated with the eculizumab, with the drug was there and was available. So based on this group, for example, based on the results of this study, there is maybe now a different type of approach compared to years ago, where we were speaking about this very like super long treatment for basically like the entire life. Again, if you look into the literature, you really don't have any how can I say, like any specific recommendation and guidelines. The general approach, and again, this can vary between center to center. Main limitation would be, for example, the drug availability. Like if they have, a center has a drug available only for, I don't know, like a month, 2 months, or only for the induction phase and not for the maintaining phase, then of course, like it's very easy there to try to define like the discontinuation. But let's assume that maybe cost and drug availability is not an issue. I would say that the current approach is that once you once you diagnose a patient with atypical aHUS, then you start, of course, the patient on the C5 inhibitor within like as quickly as possible within the first 24 hours, and then you leave the patient on that medication for at least 3 to 4 months. In this way, you will also have hopefully the time to have all the results of your complement workup back, in particular the genetic results, right? And then it really depends on what you find. So in theory, and again, this is more like suggestion, there is not like clear guidelines at the moment. In theory, the approach at the moment is that if you don't find any specific complement abnormalities, then you could consider, depending also on the experience of that specific center, you could consider to discontinue the anti-C5 treatment. Of course, it's even more when you discontinue, it's very important to monitor closely that patient. And this is considered kind of like safe approach, because as I showed before, also patients who discontinue the medication and they experience a relapse, if you restart the medication like immediately, they are able to respond. Of course, every patient is different. In this case, I'm speaking about patients without any genetic mutation. But this is, let's say, like the most common approach, like more recently. And then, of course, another like a different approach is if you find some complement abnormality, complement gene mutation. In that case, again, it really depends on the type of mutation that you identify, as where like how it was shared, as it was shared before. There are some complement gene mutation who put patient at higher risk of possible relapse, over time, and other mutations which are considered like more benign. So in particular, for example, here is highlighted that if you find factor H, C3, factor B mutation in this specific situation, maybe the recommendation would be to continue the treatment. While if you have different type of mutation, it doesn't mean that you have to discontinue immediately, but it becomes a more like a case-by-case approach. So of course, the entire team needs to, and the family as well, the patients needs to sit down and discuss about that. Again, this is like a general approach. Hopefully, the new guidelines will help us clarifying a little bit this piece. And I don't know if now or later, Christophe, you want to add a little bit more on this topic. Perfect. Now, yes, how do we access complement inhibitors? This is, I think, another big question that is there, and it's important. So what I'm showing here is the pathway that we have at SickKids, which, again, I think we are, of course, lucky. We have access to this drug, but it's not the same everywhere. So I will show in particular, just to not to take too much time, I will show in particular the pathway for eculizumab, but just to clarify, we have a clear pathway for both eculizumab and ravulizumab at the moment. And the steps are slightly different if we have an inpatient versus an outpatient. So if we have, for example, a patient who is admitted, diagnosis of atypical aHUS, we want to start immediately the medication. It's amazing because we can truly start immediately the medication. So the MRP, together with the help of the pharmacies, just need to submit a couple of forms between the off-formulary expensive drug committee, which is a specific committee at SickKids, to get the immediate approval through the hospital. At the same time, we need to submit this form for the OneSource program. In this way, the company, in particular the OneSource program case manager, will assist us and will help to get immediately, basically, the medication. So if the patient can start really within a few hours. And then for outpatient use, of course, at some point, this patient hopefully will be able to be discharged. We just need to make sure, and this is usually a process that we start at the same time as for the inpatient pathway. We need to make sure that we submit an application for the exceptional access program to make sure that also the patient also, once he's at home, is able to continue to have access to the medication and doesn't have to pay basically out of pocket. Of course, then different thing in case the patient has private insurance, but I have to say that the majority of our patients really doesn't have a private insurance who is covering this type of cost. Other thing that I wanted to highlight, and I really mentioned at the very beginning, is that we think about now aHUS in Canada, which of course is a different story, I would say, compared to the to other parts of the world. In particular, if you think about low-income developing countries, here it really looks like that the world is kind of split in two, right? You have the people the rich part and the poor part of the world, and it's always very it makes us thinking a lot about the inequity in this process. So just to give some numbers, the annual cost of eculizumab treatment for a patient, in this case average patient 40 kilos or more than that, is about in euro 500,000 euro. So it goes translated in Canadian dollars, it is between 750 to 800,000 per year. So this is considered the most expensive treatment in the field of pediatric nephrology. And until a few years ago, it was actually the most expensive drug on the market. Now, I don't know exactly what is the the score, but it remains a very expensive medication. Because of that, for example, there are countries who had to develop their own guidelines, which are different from the rest of the from the international recommendation, because they don't have access to this drug. And this is really something that needs to make us thinking. Because, for example, in India, we know in this specific case, as Priyanka will discuss, the anti-factor H positive atypical aHUS is also very diffuse. So in that case, also the combination, in theory, the combination of eculizumab and plasma exchange will make sense. But still, since eculizumab there is not available, plasma exchange together with immunosuppression to basically remove those autoantibodies becomes the milestone, which is kind of going back to the old times. We just say that we were moving from this plasma exchange therapy because it was really just treating things on the surface. So this really leads us, I think, to the summary of our conversation today. We highlighted, I think, a few points. We know that the use of complement inhibitors completely, dramatically improved the outcome of patients, short, long term. We also discuss about new therapeutic options, which has been discussed recently, and this is mainly to improve maybe compliance or reduce costs overall, because I would say that with the current treatment, we are having like a very good outcome. Drug accessibility remains a huge barrier to offer standard care everywhere in the world. And this is leads to the final question, and I'm sure that everybody has the same answer, right? Is healthcare a right over privilege? We know that it's a right, but it doesn't look like, based on how things like are developed at the moment. So I remember like the initial the title of my talk was, where we started and where we came from and where we are going. So I really hope that we are going towards like new times where we won't be here again discussing about how to access the drug and how to think about costs, but this needs to be like a treatment that needs to be like available for everybody in every part of the world. Thank you.